Our initial goal in cell therapy in 2004 was very simple-minded. We wanted to repair the permanently injured heart. We thought that putting cells in would differentiate and actually create new myocardium. Our updated goals after 16 years of discovery work are quite different and quite a lot more general, and that is to use cells, exosomes, or defined factors as novel therapeutic candidates for a very broad range of inflammatory and fibrotic diseases. And we actually don't care that much about myocardial infarction anymore. It seems to be an almost solved problem in society in terms of persistent dysfunction, and even mortality is quite rare after state-of-the-art treatment these days. So when we started 14 years ago, we thought, or 16 years ago actually, we thought that the human heart progenitor cells were easy to isolate and could be isolated by a recipe described here, with Cardiosphere-Derived cells, starting with cardiac tissue and going to explants. This is a well-described recipe, and self-assemble under adherent, non-adherent conditions and replated to create CDCs. These cells in vitro could definitely differentiate into multiple cardiac lineages. In vivo, they also seem to do so when human cells were injected in skid mice, but these were admittedly needle and haystack events. Thinking that they worked in an autologous fashion, thinking that they worked by actually creating new tissue, we wanted to use an autologous paradigm. And so we went through the biopsy and all that stuff, and we recruited patients with mild HFrEF post-MI, thinking that the mechanisms are canonical. Even after single shot therapy, 12 months later, by MRI, there were significant improvements apparently in contractility, systolic thickening, systolic thickness in the region of therapy. But we quickly realized that the clinical trials are time capsules of your understanding at the time that the clinical trial is designed. And you keep doing science, and in a fast-moving field, by the time the clinical trial reports out, it's often obsolete. This was the case in Caduceus study, in the sense that we rejected the paradigm that transplanted cells lead to new healthy tissue of donor origin, and realized that transplanted CDCs engrafted only in the short term, they secreted some kind of factor during this time and led to new healthy tissue of host origin. And in so doing, we recognized that CDCs were anti-inflammatory, immunomodulatory, and evanescent. So this led to the allogeneic paradigm and clinical trials based on this paradigm. We had revised by then our thinking to think of these more as cardiac stromal cells than as progenitor cells, although they still fulfilled the criteria for progenitor cells technically. They secreted protein factors like SDF1. And I'm going to tell you about the All-Star and the HOPE and HOPE-2 trials, which we now, which by the time we actually designed them, we interpreted as being due to paracrine effects rather than to canonical stem cell-based mechanisms. So All-Star involves intracoronary infusion down the infarct-related artery of allogeneic CDCs. It was a phase 2 randomized double-blind placebo-controlled trial of 142 patients. In order to get into EF, you had to have a recent MI, recent meaning within a year, with an EF of less than 45% at screening by MRI and an infarct size of greater than 15%. The pre-designated primary endpoint, which was scar size at 1 year, didn't show any difference between the groups, but the secondary endpoints looked rather promising in the sense that left ventricular end diastolic volume, left ventricular end systolic volume, and a biomarker of heart failure, NT-proBNP, were all significantly decreased in the treatment group. And this being a double-blind placebo-controlled trial is probably telling us that there is some disease-modifying bioactivity, even with this almost homeopathic treatment with 25 million cells down a single coronary artery, measuring endpoints 1 year later. The HOPE Duchenne trial was motivated by the recognition that Duchenne muscular dystrophy, being an X-linked recessive disorder characterized primarily by skeletal myopathy, also involves a cardiomyopathy in which over time becomes the leading cause of mortality now in these young men who often expire in their third decade due to either respiratory failure or more frequently cardiomyopathy. And this is due to dystrophin deficiency or a virtual complete absence of this shock absorber protein, which interacts with the cell surface membrane and the cytoskeleton. When it's lacking, the membranes become susceptible to rips. They let in extracellular calcium and other things that should not be in those, triggering inflammation, myocyte loss, oxidative stress, mitochondrial inefficiency, and fibrosis. Duchenne cardiomyopathy clinically is not like a myocardial infarction in which there's a scar that stays the same or perhaps decreases slightly over time. Instead, once you get any segment of the heart involved with scar in Duchenne cardiomyopathy, it becomes greater and greater and greater over time so that the heart eventually basically turns into leather. When we tried CDCs in MDX mice, which are mice that are naturally lacking in functional dystrophin due to a nonsense mutation or a premature termination codon in exon 23 of the mouse dystrophin gene. And these mice develop a cardiomyopathy and a skeletal myopathy. Here at baseline at 10 months, if you open the chest and inject directly into the heart, CDCs, they and 60% ejection fraction at 10 months is lower than the normal mouse ejection fraction at this age, which is in the 70s. The mice already have fibrotic infiltration in their hearts by then. But one CDC injection and then another CDC injection 3 months later preserved ejection fraction over the entire 6-month follow-up period, whereas if you inject vehicle at the same time, EF deteriorates progressively, tracking the natural history of Duchenne cardiomyopathy. This was interesting, but what was even more interesting to us is the fact that the mice were able to ambulate significantly better after CDCs were injected into the heart. And even though there's some cardiac dysfunction here, there's not enough to rationalize this level of functional improvement. So we suspected there was a direct benefit on skeletal muscle, which indeed we verified in this paper by directly excising the skeletal muscle, connecting it to a force transducer and measuring force. So this led to the first trial of CDCs in Duchenne patients, the HOPE Duchenne trial. In order to get into HOPE, you had to be at least 12 years old and have at least 4 segments of scar by MRI involving the heart. We recruited 25 patients with a 1-to-1 randomization protocol. And here we used triple vessel non-occlusive infusion of CDCs into the heart. The endpoints here were safety, scar by MRI, and performance of the upper limb, which is a rigorous quantitative method of basically assessing how well the patients are able to use their arms. Almost all the patients were already in wheelchairs. And so the use of the arms was basically the primary functional measure that was available in those patients for skeletal muscle utilization. Safety, there was no signal. And these data, which were reported in neurology last year, showed decreased scar over time after infusion of CAP-1002, which is the clinical formulation of allogeneic CDCs. But the usual care subjects actually saw a deterioration of scar, whereas there was a slight improvement in scar in the patients with a 0.03 p-value at 12 months. The mid and distal pull, this is the performance of the upper limb, mid being elbow and distal being wrist, showed systematically improvement in the CAP-1002 patients in each individual time. There was not significance. But if you looked retrospectively at patients with lower functioning, basically the ones that had mid and distal, by 1 year, only the CAP-1002 patients had preserved performance of the upper limb. being retrospective, we didn't put much credence in that, but we went on to do further studies. And again, clinical trials being time capsules of what we understand at the time that they're designed. By the time we completed HOPE, we realized that we could use intravenous CDCs and they work just as well. We wouldn't have to subject patients to the risk of catheterization. MDX mice receiving CDCs or vehicle intravenously showed an increase in the ejection fraction at 3 weeks after infusion, and an increase in exercise capacity and a decrease in fibrosis. And this led to a new paradigm for the follow-on trial of CDCs in Duchenne patients, HOPE-2, which is a randomized double-blind placebo-controlled trial in patients with Duchenne and with reduced skeletal muscle function. Here, we gave 150 million cells intravenously every 3 months at 9 sites. The analysis is based on the intention to treat population of the first 20 subjects. The mean age of enrolled patients was 14 years. All were on corticosteroids to avoid any confounding effect of differences in steroid therapy, which is the only thing that's been shown to delay loss of ambulation in this population. 80% of the patients were already non-ambulant. And the results really here were very striking. Performance of the upper limb was significantly, even though there were very small numbers, performance of the upper limb was markedly improved. In other words, there was deterioration progressively in the placebo group, but maintenance within almost zero changes in the CAP 1002 group. And the changes in ejection fraction were even more striking, significant to the 0.004 level, with progressive decreases in the placebo, but no change in the CAP 1002 group. The novel features of this HOPE-2 trial is it was the first trial of cell therapy with repeated sequential dosing for any indication. It was the first clinical trial of intravenous allogeneic CDCs for any indication. It was the first double-blind, randomized, and placebo-controlled trial of any form of cell therapy in Duchenne. And it was the first trial to show therapeutic benefits with any kind of intervention in non-ambulatory patients with Duchenne muscular dystrophy. So recognizing that CDCs influence cardiomyocyte survival, they're anti-inflammatory and immunomodulatory, we wondered if they might be useful in COVID-19. And we published this compassionate use series in Basic Research in Cardiology recently, showing that 4 out of 6 patients who were critically ill survived, and there was an increase in lymphocyte count over time in those patients. And this led to a follow-on trial, which I'm summarizing here. But basically, white shows completed trials. This orange color highlights ongoing allogeneic CDC trials. And here's the progression of what we've done over that time. So all start with single vessel stop flow infusion. It showed evidence of disease-modifying bioactivity with favorable changes in end-systolic and end-diastolic volume, as well as NT-proBNP. Dynamic was an open label, very severe cardiomyopathy. 14 patients studied, increased EF at 1 year, and this was with sequential multi-vessel infusion. HOPE Duchenne, I've shown you the results from. It was again triple vessel continuous flow infusion. Regress HFpEF, which is a hypertensive heart failure with preserved ejection fraction study, is ongoing. It's a randomized double-blind placebo-controlled trials comparing CDCs to placebo. Mike Zile at the Medical University of South Carolina is the PI, and the first patient in was in July 17. It's still enrolling. Alpha is studying, this is now single right ventricular infusion, allogeneic CDCs versus placebo. HOPE-2, I've shown you IV sequential doses. And Inspire, which is in COVID-19 critically ill patients, randomized double-blind placebo-controlled trial. The first patients have already been recruited and also involves IV sequential doses. So we now recognize that a lot of the action is in what's secreted and in their defined factors. And so we look forward to not only using exosomes themselves for cell-free therapeutics, but also to mining the contents to do next-gen therapeutics. And these are the folks who did the work as well as the funding sources. Thank you.